Show. This is Dr. Esther Hess.
And I am Dr. Ann Kirsch. It's a pleasure to meet you.
And
very nice to meet you
I
both.
want to welcome you to our podcast, On and Off the Spectrum.
Thank you.
For our listeners tonight, we want to, and how would you pronounce your first name? Milena? We have a frozen.
Milena.
Milena?
Okay, so we have Dr. Milena Kaufman, who is a child psychiatrist working for Kaiser Permanente, and has been gracious enough to come and talk to us about some areas of, I would say, confusion.
Yes.
For a lot of our families. So I appreciate your expertise and your clarity, and welcome.
Yes,
my pleasure.
very much.
Thank you.
Yes. I imagine that you have been beset by confusion in the field over the last 6 months or so. So can you tell us how you got into working with children as opposed to working with adults?
Sure. So I did my undergrad at UC Santa Barbara as a biologer, and I think even in my first week, there was like a email sent out to everyone under that major, and I'm sure others as well, from the Kegel Autism Center, which is in the graduate program at UC Santa Barbara. And so I joined them and started working there. That was my first introduction into autism as a freshman. And I just absolutely fell in love with these kids. And I worked as a behaviorist. So the Kegels created something called PRT, Pivotal Response Therapy, which is a more naturalistic branch of ABA. So that was really my first introduction into autism. And I really planned to just continue as a behaviorist and then stay and do a PhD. But I felt like there was some kids where I knew that therapy wasn't enough, and I really wanted to be able to wear both hats and be able to help from both angles. Med school was never my plan. I had to do a post-bac and then go to medical school, really with the goal of just serving kids and adults on the spectrum. When, I would say kids have always been my primary, but it turns out that there's not many adult psychiatrists, just the way our training goes, that then get exposure to individuals with neurodevelopmental disorders. And so as a child psychiatrist, we often sort of continue to treat these patients.
Yes.
Well, I'm appreciative both how you fell into autism and as well as working both with children and then into the adult population. I have a similar story for myself. I started off having a center for 0 to 5, but our kids started to grow up and kind of had to travel with them, and then realized that there is a terrible cliff that our post-high schoolers face, where services really are very, very poor choices, very limited, and that, as you discovered yourself, there's not a lot of individuals who have that expertise, especially traversing in terms of childhood into adolescence, into young adulthood. So I'm appreciative. We both are appreciative of a kindred spirit.
Yes, absolutely. I mean, we all kind of fit into that same brand. I always wanted to work with children, but I never thought I would only work with children or mostly work with children. And as it turned out, for me, as a family therapist, covered everything. It covered all of the people that I work with, covered families, covered children, covered teenagers, covered everybody. And it was the right fit for me and people would always say, oh, it's so hard to do what you do. How can you work with families? They're so difficult. My response would always be, I know I love that. I love that it's so difficult. I love that it's the family that I'm working with and trying to help, because it's what people need. We're all from families. We all need the help that whoever it is we're talking to, they need the help, and I feel like it's such a joy to be able to provide whatever I can.
So, with that understanding, I think the reason that we have listeners tuning into our podcast is because, without a question, families are confused. There has been a lot of very different information and guidance from the federal government that has changed and shifted over the last several months. And I think parents have shared with me, both parents with neurotypical developing kiddos, kids with developmental delays or potential for that. They want to know, for example, do the vaccinations cause autism? Is there should we vaccinate at all? Is there a cure in pill form for for autism? We're trying to create a platform here that's not in judgment as much as clarity, and so we're looking to you as an expert in the field to perhaps shine some light on some of the confusion, contradictory messages that have previously been presented, maybe where that came from and where the message is coming from today, and how do you personally guide your patients?
Sure. So I think that probably the vaccine question comes up a little bit more for the pediatricians than for me, just based on the age range. Because usually I see kiddos that, at least at Kaiser, in my previous role at UCSF, sometimes I saw 2-year-olds and up, but at Kaiser, they usually go to pediatrics for developmental behavioral peds, and we see that I'm a little bit older, kind of five and up, so kind of out of that early vaccine schedule. I think it saddens me that we're still kind of debating, if you could even say that, because it shouldn't be a debate, because, right, the evidence is very clear that vaccines do not cause autism. And that study, was very clearly, debunked that was not the case. And it does sadden me that, that's being, still talked about, how many years later, and that's still a part of parents' fears. And I understand that as a parent, right? It is very scary. And what I think is hard is that in the last, 6 months, but even further, I think there's a lot of in medicine. And I think a part of that is also, unfortunately, how medicine is set up. We don't often have as much time with our patients as we want to really, be able to sit down. And for me, I feel like when, a parent is resistant, for example, let's say it's to a medication, because of course, it's very scary to medicate a child. The most important thing for me to pull out from a parent is, let me understand the fears, because then I can address them. Please tell me, what is it specifically, right, that you're worried about? Is it a side effect, XYZ? What is it? So that then I can give you the information so that you're able to make, an educated decision for your family, as opposed to, right, it being based on fears that haven't been addressed.
That's a beautiful statement right there. Let me try to understand what your fear is so that I can help address it, is really what every clinician should be saying to their patients. Yes. But unfortunately, it's not.
Right. And so I think it's, there's obviously a lot of factors, but I think, right, it's, when parents bring up those concerns, right, often, they do quickly get shut down, like, no, this is the vaccine schedule, it doesn't cause autism, move on. And so then I think parents still leave with that same, fear. And, I wish the way medicine was set up, I wish we had more time, but I do think it's very important to understand what the parent is fearing and being able to address those. So that was hopefully somewhat sort of answered the vaccine schedule, but certainly sometimes parents, will still ask, and, I provide them with all the evidence that, that I can, and being able to kind of help. I would say even, in my own circle of friends, I have a 4-year-old and an 8-month-old, and certainly many of my friends, have, young children or are having babies and are in that. And we'll say, okay, I know it doesn't, but just in case, I'm going to ask you again, can you confirm for me? And I think, it's one thing to say, no, but I think there needs to be an explanation. No, and this is why, right? And I think that's the other piece, because if we just, say, no, it doesn't, move on, I don't think that's enough, because they're still hearing it from other venues, right? And that tell them that it does. And so I think it needs to be a longer answer so that, people can really feel comfortable. Okay, like I understand why that's not the case, and I can kind of, do what, again, feels right for my family with that information, which I, obviously as a physician, I hope is to vaccinate, because there are, many downsides. And I think that's the other really important thing that I often ask families, because in medicine, we often are taught, or the way we're trained is, here's medication, I'm going to go over the side effects. Okay. But we often don't talk to our patients, what are the side effects of not treating? Yes. And I often will ask parents that, because that's what you're really up against. It's not just, do I take this medication and here are the side effects, right? But what happens? And so I'll ask parents to kind of, weigh the two. It's what happens to my child if I don't, right? If I don't vaccinate, what are the risks there, right? If I don't treat anxiety, or, in my case, right, I obviously see a lot of irritability and aggression and anxiety. What happens, right? And what quality of life is there potentially from not treating? And I think those are the two things we should always be weighing and including in the conversation as well.
I think this was actually a conversation which we recently discussed whether women who are planning to be pregnant or found themselves pregnant and had a history of major depressive disorder, should they continue taking antidepressants during pregnancy? Again, same question. What is the consequence of not taking it? And to the impact of the health of the mother and the health of the fetus during that period of time. So it's the same idea, the quality of life issue. Can you address the question about, is there a cure for autism in pill form, as has been suggested again by some sources within the federal government?
We do not have a cure for autism in pill form, or I would say really in any form, because it's not a disease that we treat, right? The medications that we have are to treat the comorbidities that are associated with autism, right? So symptoms of anxiety, and we often see, impulsivity and irritability, ADHD symptoms. Right, are treatments that can kind of help with some of the pieces behaviorally, right, are our therapies. And that's really, if we're talking about a treatment, right, it's, speech therapy to help with speech, it's behavioral therapy to help with certain challenging behaviors, occupational therapy to help with some of the sensory sensitivities. But we do not have a cure in pill form, right, or in other form, right? It's the way, right, I describe it, right, it's a different way of seeing the world, and that's not something that we have a pill to cure.
So along those lines, could you speak to some of the concerns that parents have? I just actually assessed a child earlier today, and he is under the age of 6, and is showing a diagnosis of autism spectrum and likely a comorbidity of also ADHD. And with all of the presenting kinds of concerns, a lot of hyperactivity, a lot of impulsivity. And the question is, my little guy is not even quite 6, but when is it a good time to medicate a child for psychiatric issues? And again, side effects, consequences for not doing it. Do you have a rule of thumb in terms of age and direction? And finally, why would somebody want or need a individual who has an expertise in autism versus a psychiatrist in general, to get their guidance in terms of medication?
Sure. So I would say I don't have a specific rule of thumb. And that being said, of course, the the goal is to not medicate in general if we don't need to. And obviously we try not to medicate, little kiddos because their bodies, are more sensitive. But there's not a rule of thumb because every child and every person is different. And the way, certain symptoms may be impacting their life. And again, coming back to that quality of life. In general, if they're coming to see me, I always want to make sure there is therapy on board. Of course, sometimes also with the way things work out, the waits for therapies, depending on, different insurance companies, can take a long time. And I think since COVID, I've seen that grow tremendously where, parents sometimes are waiting up to, a year to have someone provide the therapy that their child needs. Ideal world, a 2.5-year-old gets diagnosed with autism, and first thing is really intervention, and not medication, but I've then seen 4 or 5-year-olds that are still waiting for those interventions. Meanwhile, they are not functioning well, and not being able to be in a classroom setting and not sleeping, and hurting themselves, because they're headbanging, because they're so frustrated, because they can't communicate. And so the question that I, present to families is, tell me how your child is functioning. And, for kids that young, it's functioning at home with their activities and function as a family, and then functioning in school. And if parents, tell me, your caretakers, that my child is not able to be in a classroom setting, they're not able to learn, the teachers are telling me that, my child needs to be removed from the classroom setting. They're not sleeping at home, they're not eating. That to me, I would say that your child's not functioning well, and there's a poor quality of life. And if that's what's, being brought to the table, that's when I do recommend consideration for medication. Obviously, in an ideal world would be hand in hand with therapy. But again, sometimes it means we have to do medications first because they're waiting for therapy. Or, for example, the behaviors are severe that the therapist says we can't work with this kiddo, because, they are aggressive, or, the level of kind of the dysregulation and meltdowns, they're not even able to kind of build rapport. And so we kind of need to bring that intensity down a little bit in terms of the anxiety so that the child can actually benefit from a therapeutic intervention. So I would say it's very much individually based. But of course, nobody wants to, just, start with medication. And I understand that, again, as a parent, you want to try everything else first. But sometimes we're in a place where it just makes sense to think about medications maybe earlier than a family would have, ideally wanted to.
So really listen to the environmental cues that are going on.
Absolutely, yes. I would say, most of our meds of FDA approvals are closer to 4 and 5-year-olds. And parents, of course, want that information. And so I let them know, which means, that we just have more evidence, and there's more studies around that age group. But I would say for this patient population, we often, use medications off label, or we do use medications in a different way. For example, I always start with half of the lowest dose for patients with autism because they're much more sensitive to medication. And that kind of veers into the answer of why would someone want to work with someone who has trained in autism or is an autism specialist. And I think one very important reason that stands out is that understanding behavior. So, for example, I've had an adult patient sent my way where the psychiatrist has tried many different medications and sort of presented me with the information where it was very clear that this was actually completely behavioral and a learned pattern of behavior in a very specific setting with a very specific person, as opposed to being a behavior challenge that we see in all settings. And it made sense that it wasn't getting, better with medications because it was a very, clear behavioral response to a very specific antecedent. And as psychiatrists, we don't get behavioral training in that same way, that kind of the hat that I wear kind of coming from a behaviorist background. And I often will ask families to kind of be and kind of track, okay, before I see you, in the next couple of weeks, please, write down what was the antecedent, and then how did your child respond? What was the behavior, right? And what happened after? What was the consequence, so that I can also understand? Because especially when you're treating nonverbal patients, right? They're not going to tell me, is it from, for example, elopement, right? Is it because there's a sensory sensitivity going on in the classroom, right? And the child is eloping every time when another kid yells, right? And it's very clear that that behavior is anxiety based. Whereas someone else who might not have that background understanding, they might think, oh, it's an impulsive behavior, it's ADHD, right? And you put the kid on the stimulant and they get much more agitated and much more anxious, and things got a lot worse. And so, that I think is very, very important, because you can have a lot of similarities on the surface, but what that's stemming from could be very different. And so really needing to understand that the behaviors beneath.
Well, I'm personally grateful. And our relationship happened because we had a family in common, and I was particularly impressed because prescribed medication. We want, obviously, the adage, do no harm, right? And the concern is that there was something obviously going on. And if you did not have an expertise in how certain medications can lower the threshold for certain aggressive behaviors or certain seizure type of behaviors, that you can, mistreat, not wishing to do harm, but still harm is done. And again, the reality is, as you pointed out, a lot of our families don't get a chance to be seen in as timely a way as possible, or for as long as they need when they see their physician. And so it can take months sometimes to get an appointment time. Meanwhile, the behaviors are compounding. The problems in school, amongst peers, and the home life is becoming more grievous. And I'm appreciative of having colleagues in the field who could say, okay, no, we got to make this stop, and to address from a very thoughtful place. Could you tell me what kind of training is going on now in the medical community in regards? I mean, the statistic is startling. 1 out of every 33rd child born in the U.S. is going to be diagnosed on the spectrum by the time they're 8. What kind of training specific to autism does our medical community get, so that this kind of thoughtful treatment can be found, and families don't have to suffer for the length of time that often happens?
So I think, and I say unfortunately because I wish it was standardized, but it's not. So I think it is very different depending on where you train, and even within where you train, the choices that you might make. I think autism, I think the other, hardship in medicine around autism is that it sometimes falls in a little bit, I think, of sort of no man's land, because, for example, of course, right, pediatrics covers it a little bit because, right, it's a neurodevelopmental pediatric, disorder that they see. And then developmental behavioral peds, right, they cover it to some degree, but then they have limitations. For example, if, oftentimes if a child needs certain medications like antipsychotics, right? And we know that sometimes that is a medication that individuals with autism do need for symptoms of irritability and aggression. And then for psychiatry, so much emphasis for us is, right, speaking to our patients, right? And we know there is a very large, portion of individuals with autism that are nonverbal. And that isn't often part of psychiatric training. And so I think that's one hardship, is it kind of, you would think, that, oh, great, that means all of these specialties must know. And I think the challenge is that it's covered so briefly in each one, that there isn't enough in-depth understanding. And again, because it's a spectrum. And so, right, one child with autism does not look like another child with autism, and does not respond, to medications as fairly as another child with autism. So I did my fellowship at Stanford, and for example, they had an autism clinic, which is why I chose it. But for example, my adult psychiatry residency, which was in New York, out of Northwell did not have an autism clinic. And so I, knew that I needed that. And so I did that as an elective. But my colleagues necessarily did not have much exposure, unless they happened to have a patient walk through the clinic.
You had to find
in my adult training, yes.
In your adult training,
right?
Yes.
It's shocking, shameful.
Well, because she
Yeah.
had a
So
she had a behavioral history, so
Yeah.
that she would look for it.
Yes.
And so we're so
right. And I mean, and so, similarly, not every hospital has an autism clinic, associated with it. Obviously the larger academic, settings do, but not every hospital. And so, I still have, colleagues from residency that, will text and say, what do I do? There's this, patient with autism coming through, and, we'll reach out because there wasn't enough, of exposure for them. And you can learn okay, well, here's the standards, here's what's FDA approved. But again, that may look very different, and the response may be very different than what it just says in the textbook or what's FDA approved. So it's, I wish that it was more standardized. And I hope maybe one day, kind of as, medicine catches up, in the sense that there's not enough. There's certainly not enough child psychiatrists in general, but there's definitely not enough of ones that, did we get disconnected?
No.
Oh, okay. Sorry. That have access, to be able to have that kind of training. So similarly in my fellowship, I chose to do, we choose certain clinics. And so I obviously chose the autism clinic. But that was just me and one other fellow, So other fellows chose other things, which of course, maybe that's where their kind of career led, but many people do go into more general child psychiatry. And I think that's where it's challenging, because now that the number of patients that are coming to general child psychiatrists that do have autism is growing.
Absolutely. Well, we are very fortunate that you had the early interest and pursued the training, and we hope that this message goes out to future physicians who are thinking about psychiatry to try to get a subspecialty in kiddos, because we need good docs for our children, and we certainly have to be prepared for the onslaught of children that continue to present. Actually, that may be a good way to ask you a last and probably very complex question. So when I started out in this practice, more years than I want to admit, I walked in, and the diagnostic criteria, the statistic was 1 in every 150th child who was born in the U.S. by 8 would be diagnosed, and that has now rapidly descended to 1 in every 33rd child, as I mentioned. Can you give thought as to why there is such a huge rise in autism spectrum disorder, and speak to, I guess, both the diagnostic capabilities and beyond?
Sure. I think, the largest sort of change was when we, had the separate diagnosis of Asperger's, and when that no longer, became a separate diagnosis, and all of that became absorbed by autism spectrum disorder. I think that made the largest change in terms of, now the diagnostic criteria is much larger. And so it needs to encompass that, because before, the number only included very specifically autism spectrum disorder, as well as before we had PDD-NOS, pervasive developmental disorder, none otherwise specified, which, were kids that didn't have all of the criteria, and only met some. Kind of on the other end, we had PDD-NOS, and then autism spectrum disorder, and then Asperger's, and similarly, became absorbed. So we really sort of had 3 separate diagnoses, and 3 separate, I would say, numbers in terms of frequency, and that all became absorb in terms of autism spectrum disorder, mainly in order to be able to get more services for these individuals, because oftentimes for insurance criteria, you had to meet specifically autism spectrum disorder to get certain services covered, when it was very clear that someone with PDD-NOS would, benefit very clearly from the same sort of services, right? Or on the other end of the spectrum, right? Someone with Asperger's would still very much benefit from certain interventions. So that really is the largest contributor to how that's changed. I also think, of course, social media plays a role, right? And people sort of learning for themselves and kind of being able to identify certain things. And my hope is, right, to some degree, we've been hopefully chipping away at certain, biases in mental health care, and being able, right, to that it's not something, right, that we need to sort of, right, hide. It's something that we need to kind of figure out how to get the right support so that we can, benefit. And I mean, again, just coming back to that quality of life piece. So I would say those are probably the two biggest contributors to that number, that ratio.
Okay, well, I'm appreciative. I'm also aware that children of color have become they are also being addressed in terms of diagnosing, and I think overall, I think we're all better at diagnosing. Period. So I think it's a combination. But I agree with you. I think the combination of one big umbrella, autism spectrum disorder, as of 2013, has made a huge contribution to the increased numbers. But I will tell you that as long as we have good clinicians like yourself in the field, I think I consider ourselves very lucky. And I want to share that tonight we clarified, I think, some very important pieces that have just added confusion to our family search and trying to find answers for the complexities of raising children in 2026. So we both thank you for being part of tonight's podcast. And we're going to sign off. So let me just say thank you. This is Dr. Esther Hess.
And I'm Dr. Ann Kirsch. And I truly appreciate hearing what you as a clinician have to say about what your journey has been like, and what you've gone through, what your life has been like as a clinician, because we've all experienced that, and it is not easy, and it is at times quite difficult to get people to pay attention to what it is, the questions we're trying to ask, what it is that we really want people to know, so that the kiddos that we're working with get the best care that they can possibly get. And in our time, working for a long time in this field, I've seen it get better. I've definitely witnessed changes happening that are kind of stunning, I would say, in the efficacy of what I'm witnessing, what we're witnessing. But there's so much more to do. There's so much more that needs to be done. And so as we go through our podcast and we interview people like you, we really closely listen to what you're saying, it makes me glad, on the one hand, that there are people like you who are fighting the good fight, really out there, really, really paying close attention. And there's so much more to do. So I'm grateful to be able to speak to you.
We are on and off the spectrum.
My pleasure.
This is a podcast that listens to your concerns and voice. We thank again Dr. Milena Kaufman, who has joined us for the evening, and we wish all safety and a good night.
Yes.
Thank you for having me. Have a good night.
You.
Okay, please
Good
take
night.
care.